So I'm going to take about 45 minutes, maybe 50 minutes, to kind of give you an overview of some of the general anatomy of the knee, a word or two about technical considerations, and then I will, in fact, early on in this talk, cover a few fat pad abnormalities that I find very, very interesting in the knee, and I'm sure you have seen these as well. Let's begin by looking at the surface of the bone, and we will look at the anterior aspect of the distal femur. As you look at this, I have put arrows on a very interesting ledge of bone. That is the superior surface of the patellar portion of the distal femur. I know we call the patellar surface the trochlear surface, but anatomists tell me that is an incorrect term. I still use it in my imaging reports, but this is the part of the knee where the patella and femur articulate. And I want to make the point about the anatomy that as we proceed from the lateral side to the medial side, you can see that that articular surface slopes downward. So it's higher on the lateral side and lower on the medial side. And that has some MR imaging importance, as I'll show you in a moment. You'll note here the more prominent medial epicondyle than the lateral epicondyle, and you'll see distally the flattened surfaces of the medial and lateral condyles of the femur. If we look at the posterior aspect of the distal femur, we can see again how much of these condyles extend posteriorly. These are important weight-bearing surfaces, particularly as the knee is flexed. These portions of the condyles roll down and contact the tibia. Between the two, the intercondylar fossa can be seen. There are described in the literature medial and lateral supracondylar lines on the surface of the bone. I show you them there, and I wanted to point out also the prominent adductor tubercle. This is an important landmark that we see on MR and CT images, and Minnie tomorrow, when she discussed the medial supporting structures of the knee, will certainly concentrate on all those things that attach to the tubercle or around the tubercle. It's a very, very crowded area of the knee. This is a lateral view of the medial femoral condyle, and the arrow is pointing to a flattened area that separates the condyle into an anterior 1/3 and a posterior 2/3. It actually looks a little bit more like 1/4 and 3/4. Now, the medial condyle is a lot smoother than the lateral condyles, you will see in a moment, and there may not be a flattened area or a notch where the arrow is. But in many of us it is a normal finding. And what it is telling you is the point of separation of the patellar or trochlear surface of the medial condyle and the true weight-bearing surface of the medial condyle. Normally we never do weight-bearing anterior to this particular point. It is true that the patella may ride down below this point, but we never weight bear more anteriorly than this point. On the medial side, if you see this, it will be very far anterior as shown here. But when you compare that then to the lateral side, you can see a major difference. On the lateral side, there is a considerable flattened area that divides the lateral femoral condyle into two equal halves. So this is, again, a sulcus between the weight-bearing condylar surface and the patellar surface, and in fact, both of these points are known as condylopatellar sulci. You all have seen this on radiographs. We sometimes call it the normal notch. We're going to learn about it, obviously, tomorrow when we talk about deepening of this notch in cases of anterior cruciate ligament tears. But this allows you on radiographs and certainly on MR to separate the medial condyle from the lateral condyle based upon the location and prominence of the flattened areas. Finally, on this image, you can see the groove through which the popliteus tendon passes. This can be very, very prominent and sometimes actually look like a lesion. The femoral condyles articulate on tibial condyles, medial and lateral, as shown here. Between the two is an elevated area that I'll talk more about tomorrow, This is the intercondylar eminence of the tibia, and that intercondylar eminence has two tubercles, a medial intercondylar tubercle and a lateral intercondylar tubercle. In some of us, there will be a third tubercle noted anteriorly called Parsons tubercle. These tubercles become more prominent and pointed in patients who have osteoarthritis of the knee, although the exact etiology for that pointing is not entirely clear. Taken from Netter, this drawing indicates the size of the knee joint. It is the largest and some would say the most complicated of joints. There is an extensive synovial membrane now shown in red on this drawing, and you can see that that synovial membrane extends far above the level of the patella in the form of a suprapatellar recess or pouch. In most of us, there is no obstruction to flow of fluid between the suprapatellar pouch and the remaining portions of the knee joint. But as you'll see later in this lecture, we'll talk about a plica that may obstruct flow between the two. Below the patella, we can see the synovial membrane is reflected over a large fat pad. This is the fat pad of Hoffa. I'll show you in a moment that this is a great place to look for evidence of an aggressive synovitis going on in the knee. And posteriorly, you can see that the synovial membrane in this drawing anyway is reflected over the edges or peripheral portion of the meniscus. We'll return to that point as we talk about the meniscus in the next lecture. There are very prominent intracapsular and extracapsular fat pads intimate with the knee joint, and so I thought we would start our discussion dealing with those fat pads. So here is a drawing that I made taken from that last picture to indicate the location of three major anterior fat pads. Number one, of course, is the infrapatellar fat pad of Hoffa. Number two is the suprapatellar fat pad. And number three, often a thin sliver of fat located anterior to the femur, is known as the prefemoral fat pad. Certainly numbers 1 and 2 are intimate with the extensor mechanism, and number 3 is not far behind. So it should surprise no one that there is perhaps an important relationship between changes in these fat pads and alterations in the extensor mechanism, particularly in areas 1 and 2, maybe not so well established in area 3. Whenever we see edema or fibrosis in these fat pads, we always suggest the possibility of altered patellar tracking, because there is a relationship between the two. If we go ahead and look at our first example or examples, I wanted to show you inflammatory changes occurring within the prefemoral fat pad. The relationship to altered patellar tracking, not well established here, but I suspect we will find one. This can be symptomatic and a cause of anterior knee pain. The second location I show you is edema involving the suprapatellar fat pad. Here, this is associated with altered patellar tracking. It is associated also with quadriceps tendinosis and even partial tears of the quadriceps. And so it is a observation that you should report on when you view the imaging study. Sometimes it's not so much edema, but enlargement and fibrosis as shown in this particular example, but I think the importance of the observation remains the same. The third fat pad we will look at is Hoffa's fat pad. A very common finding that we see, particularly in young people and more often in women, is edema involving the superolateral aspect of Hoffa's fat pad as shown here. This is not very dramatic. In some cases it is certainly more profound, but this is an important observation. This is a clear cause of anterior knee pain. It's associated with patella alta, as it is in this particular case, and then associated with altered patellar tracking. So this should be noted in your report. This is a significant finding. And it's easily overlooked unless you have a method of examining these fat pads routinely at the time of MR imaging. I certainly do that because otherwise I would miss these. There's another form of edema that occurs when in Hoffa's fat pad that involves mainly the deep portion as shown here. I suspect, although I have no proof, that this relates to fat pad impingement in certain positions of the knee. I've seen this more common in women than in men, and it again likely indicates some problem with the extensor mechanism. Diffuse involvement of Hoffa's fat pad is sometimes called Hoffa's disease, although the importance of it is not entirely clear, and the etiology is probably varied. The Mini Pathria and some of my other associates have suggested and reported that this is associated with HIV infection, and whether it's the infection or the therapy, I am not entirely sure. This clearly can be quite prominent, as in this particular case. Others feel that this is a form of fat necrosis, but I'm not sure. But you should report this and do not forget to indicate that this could be a cause of anterior knee pain, because they may not be aware of this entity. If we return to that interface of the synovial membrane in Hoffa's fat pad, what we have found is the more aggressive the synovial process, the more likely that we will see obscuration and effacement of that interface between the synovium and the fat. Typical diseases that do that are rheumatoid arthritis, as shown here, pigmented villonodular synovitis, and septic arthritis. A bland effusion, as one might see with an internal derangement, may cause minor changes, but not changes as extensive as what is shown here. So this is a good way to sort out the nature of the joint process, looking at that interface between synovial membrane and fat. One other point that I would like to make is the occurrence of fibrosis in this area, pointed out by the arrows. This is the interface, again, of the synovium and Hoffa's fat pad. It is sometimes called the anterior interval of the knee. There have been some reports in the orthopedic literature that this is a significant pattern of fibrosis, generally seen following arthroscopy, as in this case, and may lead to restricted knee motion. So we generally indicate at least involvement of the anterior interval of the knee. Finally, with regard to fat pads, we move posteriorly, and I show you something that I learned from some of the previous research fellows from Brazil. On one of my trips there, they indicated to me they were seeing athletes, particularly soccer players, who had pain in deep knee flexion. And the MR images were showing this inflammatory reaction in the pericruciate fat, mainly located behind the posterior cruciate ligament. I've seen a few of these cases, but the most dramatic ones I've seen are the ones that were shown to me when I was in Brazil. Has anyone seen this? Okay, I think that this is a significant finding. Again, inflammatory changes about the cruciate ligaments. Keep that pattern in mind as well. The second area that we will concentrate on, at least for a few minutes, relates to the articular cartilage in the knee. This is a drawing, obviously, showing you a sagittal view of the knee, and I've colored in the articular cartilage in light blue. Clearly, we recognize that the articular cartilage in the knee is among the thickest in the human body, and that of the patella is extremely thick. So that is why most of the reports of imaging sequences used to evaluate articular cartilage have explored how good they are in the knee, and particularly in the assessment of the patellar cartilage. We evaluate this articular cartilage certainly in every knee MR examination. If you look at your transverse images, and this is the level of this one, I want you to note that when you sample the articular cartilage on a high transverse image through the patella, you are not sampling the trochlear cartilage. So it's very easy to say, boy, look how pretty this articular cartilage is, and there's extensive loss of articular cartilage in the trochlear surface. That is why whenever I evaluate the articular cartilage of the patellofemoral joint on axial images, I split the screen and I have a sagittal image right alongside, because I certainly want to know what level I'm at and be sure it's a level that's proper to assess patellar cartilage and trochlear cartilage. This is not a proper level. It is too high to look at the trochlear cartilage. As we go down lower, of course, the trochlear cartilage will come into view, and this is showing you now a beautiful articular surface here. So do not evaluate that surface on the high axial images through the patella. Furthermore, as you know, the shapes of the patella vary incredibly, and sometimes there is a very prominent inferior pole. What that means is a lot of the lower portion of the patella contains no cartilage. You don't want to overread that absence of cartilage as a pathologic finding, because it is a developmental finding. Let's look at this in one other way that I think is interesting. We'll take away the patella and we'll look at the trochlear cartilage. Almost invariably, when you look at the trochlear cartilage as you come from above and move down, it is the lateral trochlear cartilage that appears first. And that relates to that sloping surface that I pointed out on the first slide of this talk. So you have to realize that and then not say, well, gee, there must be loss of articular cartilage on the medial aspect of the trochlea. Actually, you can see the cartilage extend toward the medial side as you go lower and lower on your images. Once it occupies the entire surface of the trochlear, you can then be very critical about problems with the trochlear cartilage, as shown here. So please remember that lateral trochlear cartilage appears more superiorly than does medial trochlear cartilage. I think now with good magnets and high-resolution images, we do well with the patellar cartilage. Reports have indicated we do not do as well with the trochlear cartilage. And one of the reasons is that as you go down, this is a dramatically curved surface, and it becomes very difficult to really see it. So what we rely upon heavily in our assessment of trochlear cartilage is the common presence of subjacent cystic changes in the bone. If I see cystic changes beneath the trochlear surface, even if I don't see the cartilage, I tend to suggest that that trochlear cartilage is abnormal. There are three classic facets of the patella. They're shown here. The lateral facet, which in most of us is the broadest, a medial facet, which typically is obliquely oriented, and a most medial or odd facet, which has a steep oblique or even a vertical appearance. We expect to see articular cartilage in the medial and lateral facets. It may or may not be present on the odd facet. And it is not uncommon for it to become smaller and smaller as you proceed anteriorly. You don't want to read that as loss of articular cartilage on the odd facet. As you look at the shape of the articular surface, that is of the cartilage shown in yellow arrows, and you look at the shape and configuration of the subchondral bone plate of the patella, you can see they are not parallel. Some people have suggested that this anatomic relationship that explains the high frequency of shear injuries and chondral delamination of the patellar cartilage. So I show you an example of vertical and horizontal delamination involving the articular cartilage. There's also fibrillation of that surface as well. One other point I would make as we look at the patella is shown in this particular slide, and that is the ability to see hypervascularity in the bone. Now, you'll see this in other bones about the knee, but it is generally most prominent in the patella. and it leads to a bone-within-bone appearance. You get this linear or spotted peripheral area of intermediate signal intensity, which you can see very, very nicely in the axial plane. You see it in the sagittal plane and coronal plane as well. This indicates hyperemia, as I mentioned the other day. It is not specific for a single condition. It can be seen in a variety of conditions. It can be seen in any cause of aggressive osteoporosis. So certainly something we could see with reflex sympathetic dystrophy or regional pain syndrome, and even sometimes in cases of disuse osteoporosis. It's also been described in an article indicating it is a finding in the subacute phase of an injury to the knee. So following an injury, you may see this bone-within-bone appearance. By itself, it certainly does not cause pain. In the next lecture, I'm going to go into great detail as we begin our discussion of the menisci, so just a couple of points using this slide from Netter. You're looking down on the top of the tibia. Medial is to your right, lateral is to your left, posterior up at the top, and anterior at the bottom. The shapes of the two menisci are not the same. The medial meniscus is more elongated. The lateral meniscus is more circular. They both cover part of the tibial articular surface, but the degree of coverage is greater on the lateral side than it is on the medial side. Now, we've already heard the importance of sparing as much of the meniscus as possible if you're considering surgery. But if you were to do a total meniscectomy, the effect would be more detrimental on the lateral side than it would be on the medial side, because more of that tibial articular surface is covered by the lateral meniscus than the relationship on the medial side. The cruciate ligaments are intracapsular and extrasynovial. Here, of course, one of the ligaments that connects the meniscus. It is not the only one, but it is the most common one we see. This is the antertransverse meniscal ligament. There are posterior meniscal ligaments, and there are oblique meniscal ligaments, but the frequency of the anterior one is most common. Here's a drawing, of course, of that antertransverse meniscal ligament. I would point out to you that it extends from the very tip of the anterior horn of the medial meniscus to the convex anterior surface of the lateral meniscus. It does not extend to the inner tip of the lateral meniscus, because if it did so, it would sweep posterior, meaning that the attachment points of the lateral meniscus are much more centrally located than the attachment points of the medial meniscus, and I'll talk more about that in the next lecture. Here is the way it would look. It's a variable thickness. Sometimes it is not complete, it is incomplete, and in our experience, when incomplete, may be associated with inflammatory changes nearby. But this is the antertransverse meniscal ligament. Another bit of meniscal anatomy that I think you all know is the way the popliteus tendon sheath is related to the posterior horn of the lateral meniscus. Here is the tendon sheath as we look at a lateral view of the knee. It sweeps from a more anterior position above to a more posterior position below, and it separates the lateral meniscus from the joint capsule. Because of this, the lateral meniscus cannot attach to the capsule over a long or broad area. Rather, it attaches to the capsule by way of popliteal meniscal ligaments, two of the three being shown here. I'll talk more about these ligaments when we talk further about the meniscus, but you should be aware of this relationship. Let's turn our attention briefly to the medial supporting structures, recognizing that Minnie tomorrow will go into much more detail. There are many of these. I've labeled some of them here. You can see the medial collateral ligamentous complex, the posterior oblique ligament, and pes anserinus tendons, as well as portions of the patellar retinaculum. Let's use this diagram to briefly introduce you to the terminology that we use to describe this side of the joint. All of the supporting structures on the medial side are called the medial collateral ligamentous complex, and there are a number of them. One of the major structures that we see, shown in blue, is the tibial collateral ligament, which is the superficial part of the medial collateral ligamentous complex. Deep to that, shown in yellow, is the deep medial capsular ligament, which consists of a meniscofemoral portion and a meniscotibial or coronary portion. Between the two, there is a bursa shown in red, and it is not uncommon to get fluid within that bursa. The amount of fluid varies from one person to another. There are examples of bursitis, but most of the time, that fluid is not symptomatic. We see the tibial collateral ligament very well on our coronal images. It extends from a proximal attachment near the epicondyle across the joint line with no connection to the meniscus, and then attaches far distally, way below the joint line. The classic descriptions are it does not attach up here, although it may be pressed against bone. Recent anatomic descriptions, however, have suggested there is a proximal attachment of the tibial collateral ligament, but most of us still consider the main attachment to be way below the joint line, with genicular vessels located between the ligament and the surface of the bone. Typically, we see the outline of this ligament very well because there is clean fat just exterior to it. If we take away the tibial collateral ligament or cut it, we see that deep medial capsular ligament. It is not very broad. It is located in the mid portion, as you can see here, and indeed there is strong capsular tissue more posteriorly, but this is not considered ligamentous. So this then is the deep medial capsular ligament. A very important part of the medial collateral ligamentous complex is the posterior oblique ligament. It's so important that some orthopedic surgeons will consider operation if this part of the medial supporting structure is injured. Minnie tomorrow will explain to you how we diagnose injuries to this particular ligament, but I just wanted to show you the three major arms of the posterior oblique ligament. Some of them are parallel to the tibial collateral ligament, some are more oblique, and some are even more oblique and extend to the posteromedial corner, where they have fibers that are attached to portions of the semimembranosus, SM in this drawing, as well as fibers that contribute to meniscocapsular tissue about the posterior horn of the medial meniscus. So this is a very important ligament. Now, although we don't necessarily mention it in our MR reports when there is no injury at all on the medial side, we will say the medial supporting structures are normal. We will specifically mention it if, in fact, we're dealing with an injury on the medial side. We go through a checklist of which structures on the medial side are injured. The checklist includes the tibial collateral ligament, the deep medial capsular ligament, the posterior oblique ligament, the semimembranosus muscle and tendon, the medial head of the gastrocnemius, and part of the retinaculum known as the medial patellofemoral ligament. So we have a checklist that we will go through one by one. When we're dealing with an injury on the medial side, we'll indicate the status of each of those particular structures. On the lateral side, we have numerous structures that we deal with. This is a short list. There are certainly a lot more. The most complex anatomy on the lateral side is in the posterolateral corner of the knee, and we can introduce you to that anatomy using Netter's drawing. Here you can see the fibular collateral ligament arising or extending from the epicondyle downward to the fibula. It becomes intimate with the biceps femoris tendon. Whether they join together or next to each other in the fibula might be debated, but they certainly become intimate distally. We have the popliteus muscle that extends or curves around the knee joint to attach more proximally on the femur, as I mentioned earlier. In this drawing from Netter, a very interesting aspect is the arcuate ligament. Now, there's a debate about what are the components of the arcuate ligament, and there are other ligaments right nearby, such as the popliteofibular ligament. But the main point I would make is a lot of these smaller structures that are hard to see are located just superficial to the myotendinous junction of the popliteus. So the finding of edema just superficial to the myotendinous junction of the popliteus is pretty good evidence you've got a problem with the smaller ligaments in the posterolateral corner. It should be on your checklist of observations you need to make. As we look at a very posterior coronal image of the knee, it's dominated by the biceps femoris tendon, which is shown in yellow with yellow arrows here. If we go one cut forward from there, we see the fibular collateral ligament swinging up toward the epicondyle. Just deep to it, we can see the popliteus tendon. On an MR image about at that level, we see the fibular collateral ligament. We can see the biceps femoris muscle becoming a tendon in the same area. So a lot of structures in a very small region in the posterolateral corner of the knee. In the sagittal view, you can check for this particular V. The fibular collateral ligament and the biceps femoris tendon come together in the form of a V. And if your sagittal images go far lateral enough, you'll be able to check for this particular V and the integrity of these two structures. There are many meniscofemoral ligaments. Now that may surprise you because the ones you hear about are the two I show you here. I'll show you another one as well this afternoon, but there are other ones. But these are the most important ones, and they are two in number. The ligament of Reisberg, which is shown in the four images on the right, which extends upward from starting on the lateral side near the meniscus and curves upward and is located just behind the posterior cruciate ligament. Sometimes it doesn't go all the way up to the femur. It merges with the posterior cruciate ligament and creates a bump on its surface. The anterior ligament in front of that posterior cruciate ligament is the ligament of Humphrey. I learned not too long ago, and unfortunately it was late in my career, that Humphrey is spelled just as you see it on this slide. There is no E in the ligament of Humphrey. Unfortunately, I have many articles and books that have placed an E in that particular word. So that is the ligament of Humphrey. The iliotibial tract extends along the lateral aspect of the thigh and has complex attachments at the level of the knee. The major attachment is to Gerdy's tubercle, and Minnie will talk about injuries to Gerdy's tubercle. When looking at that iliotibial tract, it's a nice place to look for abnormal collections of fluid. Even small joint effusions often first appear just deep to the iliotibial tract. And in the iliotibial tract syndrome, an adventitial bursa forms just deep to it, and edema and fluid may become present within that bursa. The central supporting structures are the cruciate ligaments, 2 in number. They both are intracapsular and extrasynovial. The anterior cruciate ligament is weaker than the posterior cruciate ligament and is more often injured. Its fibers twist during flexion and extension of the knee. Despite occasional articles, very few, that say there are more than 2 bundles, most articles indicate there are 2 major bundles of tissue, the anteromedial bundle and the posterolateral bundle. These bundles are named after their sites of attachment on the tibia and often can be seen and separated on your MR examination. There's a lot of renewed interest in these two bundles. And in fact, as you probably know, some surgeons like to replace or reconstruct them, both bundles. And so they look at the placement of the anteromedial bundle and the placement of the posterolateral bundle as separate issues. There is some evidence to suggest the function of these bundles is different. I'll talk more about that in the last lecture of this course when we discuss the cruciate ligaments. You all know the way we quickly assess whether or not the anterior cruciate ligament is normal or abnormal. We turn to the sagittal image. We find the roof of that intercondylar notch. We find the anterior surface of that anteromedial bundle. And if that line of the cruciate ligament is parallel to or steeper than that of the roof of the intercondylar notch, we generally put a check mark that the anterior cruciate ligament looks pretty good. And that's a good general rule, but as we'll talk about again later in the course, there are 4 or 5 patterns of fibrosis that take place in chronic ACL tears. One pattern to the adherence to the posterior cruciate, and one pattern is adherence to the roof of the intercondylar notch. And in both of those situations, you end up with the surface of the ACL that will look exactly like a normal ACL. So sometimes you can be fooled by a chronically torn anterior cruciate ligament with considerable fibrosis. We check the anterior cruciate ligament also on the other planes. Here we can see it, and this is a very important plane in the transverse plane as it approaches the lateral femoral condyle. And in the coronal plane, we also want to check it to see if it looks normal. The posterior cruciate ligament is a stronger ligament, and as you can see, it attaches well below the joint line to this sloping posterior surface of the tibia. Hence, when you check it on your axial images, you've got to start well below the joint line. You can see it is intimate with those meniscofemoral ligaments that I mentioned. There are 2 bundles here in most reports, an anterolateral and a posteromedial. I believe many will talk about 4 geographic zones of this ligament because others have emphasized the zonal arrangement of fibers within the posterior cruciate ligament. The posterior cruciate ligament complex consists of the posterior cruciate ligament and the meniscofemoral ligaments, particularly the ligament of Reisberg. And it's important to think of these tissues as a complex because, in fact, the meniscofemoral ligaments, particularly that of Reisberg, serve as small posterior cruciate ligaments. And indeed, following a tear of the posterior cruciate ligament, the presence of a ligament of Reisberg that is big carries a better prognosis. So whenever you're dealing with tears of the posterior cruciate ligament, a comment should be made as to the presence and integrity and size of meniscofemoral ligaments. This is showing you the situation where this ligament of Reisberg terminates within the posterior cruciate ligament. It looks thick there, but that would be a normal finding. In order to check quickly the status of the posterior cruciate ligament, we look for a structure that is smooth. We look for one that we can draw a line that is tangent to the distal surface of that posterior cruciate ligament that, when extended superiorly, intersects the roof of the intercondylar notch. If that line is more vertical and parallel to the back of the femur, it suggests that the tibia has moved forward and you have a tear of the anterior cruciate ligament. We use fast spin echo as our standard technique to evaluate the knee. We rely on both fat-suppressed and non-fat suppressed images, and we image in 3 particular planes. Now, these are showing you the imaging plane, so it is a transverse plane, and then we get a true coronal, and then a slightly oblique sagittal, which is more parallel to the anterior cruciate ligament. My favorite sequence is the coronal fat-suppressed T2 weighted or intermediate weighted sequence, because indeed it shows you areas of bone contusion and fracture. It shows you areas of ligamentous disruption, and it gives you at least some idea as to the integrity of the menisci. I do not think this is ideal for looking at the menisci, but at least it gives you some information about the menisci. This is the way I review images of the knee. I typically start sagittal, then coronal, always going anterior to posterior in the coronal plane, and then I mix the coronals often with axial, always going superior to inferior in the axial plane, and then various switches after that. We'll finish up in the last 10 minutes by addressing only one particular synovial topic, and that is the topic of synovial plica. It is believed that plica are normal during development, but typically they resorb in various stages of development, but when they persist, they remain in the knee joint, where they often produce absolutely no problems. They're thin, they're slender, they're delicate, and we might note them but call them physiologic. Most normal plica are 1 or possibly 2 millimeters in thickness. Most diseased plica are greater than 2 millimeters in thickness, although there is some overlap between normal and abnormal thickness. There are 4 types of plica. I'm not going to discuss the lateral plica because they are very infrequent, but a few comments about the other 3. The superior plica is located a few centimeters above the patella, shown by a yellow arrow in this particular slide. It runs from an antero-inferior point to a postero-superior point. It may be complete, that's not good. It is often incomplete with a large opening or porta. That's a better prognosis if there is a large opening. Normally transparent, as I suggested. You can see that it partially separates the supratellar pouch from the remaining portion of the joint. The inferior plica, also known as the ligamentum mucosum, sits just anterior to the anterior cruciate ligament. It is intimate with the infrapatellar fat body. Sometimes, if it is thick, it can be mistaken for a normal anterior cruciate ligament when the anterior cruciate ligament is torn. And in fact, that was a real problem when we used to use arthrography of the knee to evaluate the anterior cruciate ligament. Here's what a normal plica would look like, and you can see it is pretty thin and located just in front of the anterior cruciate ligament. This is a normal plica, and it shows that it can extend far anteriorly, and as I'll show you in a slide, it can also extend up to the inferior pole of the patella. Note that it typically curves before it reaches the level of the joint and the menisci. I tell you that because there is another structure that looks very, very similar to it, which is known as the anteromedial meniscofemoral ligament. This ligament, shown here, arises from the anterior horn of the medial meniscus, so it doesn't curve up as like a ligamentum mucosum would, but it does extend up and looks very much like a ligamentum mucosum. There is a higher likelihood of tearing of the medial meniscus when there is an anteromedial meniscofemoral ligament. Here's an example to show it. This is a prominent one, anteromedial meniscofemoral, attaching to the meniscus with a tear at the point of attachment. You can see that that ligament can create regions of low signal, linear or circular, that can simulate pathology. The medial plica is the one that in fact has gotten most of the attention. It is a shelf of tissue that extends inward toward the patella, as shown by the yellow arrows. There are a lot of other synovial structures in the medial gutter of the knee with which it may be confused. Now, I put these 2 images up together to show you a true plica on the left and a pseudo plica on the right. You can be certain there is a plica if you have fluid in the joint and there is fluid on either side of this horizontal area, this line. But if you have something like this with a broad band of low signal running to the patellar cartilage and you have fat rather than fluid in front of it, you be very careful calling this a plica. This is not a plica. This is the collapsed suprapatellar pouch of the knee joint. If there were a plica, it would be in the middle of that broad band and you can't see it because there's no fluid within the joint. And if you think back on the way that you diagnose knee effusions on lateral radiographs, you use the location of two fat pads and you measure the density in between. You're measuring this density between these two fat pads. So this is the suprapatellar pouch. We'll finish up in the last few slides by talking about the plica syndromes. I've listed what syndromes have been reported to occur with which plica. And we're not going to talk about the lateral plica because the relationship to iliotibial tract syndrome is not entirely clear. The medial plica syndrome is seen especially in young athletes, more often men. The number of sports that have been associated with problems with medial plica are many. I've listed some of the more important ones there. In my experience, it has more often been with cyclists and runners than any other sports. The symptoms may begin after blunt trauma. That's certainly not consistent. There is pain, particularly medially, that increases with movement of the knee. And the orthopedic surgeon who is good would tell you that he or she can palpate a cord that is painful and that the diagnosis can be made clinically. The McMurray test, a test typically reserved for meniscal tears, may be positive in cases of medial plica. Here's an example of a thickened medial plica, and you can see its relationship to the nearby articular cartilage of the patella and femur, where places where you may develop cartilage abnormalities. This is the typical pathology that I have seen. This is a medial plica that is minimally thickened. But you can see that there is a cleft here in the articular cartilage of the patella in the medial facet. And that is the relationship that I think of as most established for medial plica syndrome. This one more dramatic, a very thick plica. You can see where it is on the sagittal images. The superior plica syndrome is also important, has a different presentation. If you have a thick superior plica, you have abnormal compartmentalization of the knee joint. So the fluid does not pass in an unrestricted way between the suprapatellar pouch and the rest of the knee. It gets held up. So the usual finding is synovitis, somewhere near the location of this particular plica. And because of that, in some cases, the actual presentation is a mass. You'll get this rule-out tumor. Here is a plica in a cadaver, and you can see how it closes off the connection between the suprapatellar pouch and the remaining area of the knee. This is what it would look like, and in this particular case, you can see the synovial proliferation above it, and in this case, a slightly thickened medial plica is also evident. Sometimes you can see on plain film that there's something strange going on. There is what looks to be a large joint effusion, but there was no effusion elsewhere in the knee. In addition, there were some areas that were more lucent within this dense effusion. The MR shows you the thickened superior plica, fluid pretty clear above it, a lot of synovial proliferation, fibrofatty cellular infiltration. This is the superior plica syndrome. And it may become dramatic, as in this particular case, where the patient presented with a mass. This was a completely closed porta. So this is a mass of synovium and fluid, and indeed it looks nodular. There are reports, actually, of pigmented villonodular synovitis confined to the pouch above a markedly thickened superior plica. And the inferior plica syndrome, again, not entirely clear what it does, but some people think that when it's thick and fibrotic, it leads to retraction of the extensor mechanism. There are reports of injury to this. There are 1 or 2 articles in our literature that have talked about how this plica may become torn, and it does make arthroscopy more difficult. Here's an example of a very, very thick ligamentum mucosum lying just in front of the anterior cruciate ligament. As you look at this particular slide, you can appreciate that there may be another strand of tissue, because this plica can curve all the way up to the inferior aspect of the patella. In some cases, you will see strands of tissue extend down to the patellar tendon. Here's an example. This patient did not have arthroscopy, because certainly arthroscopy could do that, but this is thickening of that ligamentum mucosum with connections to the patellar tendon, maybe explaining contracture of the extensor mechanism. What are the criteria to resect a plica? Well, it depends on the orthopedic surgeon, but here are some of the things that are suggested. Often, and if they do diagnostic arthroscopy and they find nothing but a plica, they will remove it, operative arthroscopy, and indicate there was a plica syndrome. So this is often the last step that is done. I'll show you how the surgery is done. I do it in a bloodless fashion using PowerPoint. Here is that plica, all right? I'll go ahead and put in a scope through a portal and grab it. I'll put in another portal just to see it better, maybe a favorite scalpel. I'll cut away at it, right, and resect it, and then everything is removed cleanly, not a drop of blood, and you're left with this sort of situation. And so when you look at these following surgery, you may see something like this, as in this case, following resection of the plica.